even just being able to have those kinds of conversations with people so that patients can hear what that sounds like, I'd be interested in that. I just have to wrap my mind around it a little bit more. Have you thought about that?
I think I have actually. And I think, part of it is that we're so busy in the clinic, just seeing the patients, but there's so many patients that have pretty similar things that, these are patients, it's hard for them to read stuff. And I always feel bad. We give them pamphlets, but they're, it's almost a kick in the teeth, right? Like, you're having trouble with your eyes. Here, go home and read this pamphlet. Like, really?
Yeah.
But having something to listen to, a lot of them are hard of hearing in our practice, but still they could put on some headphones, and it would be a nice thing that the office could say, hey, these docs were talking about your treatment of wet AMD. Why don't you listen to this? And so here's a link to it. And, podcasts have become, at least for me, I listen to podcasts all the time when I'm working out or when I'm riding my bike. I'm listening to them all the time. And it's really a great platform. And I don't know. Are there people that do this for patients? I assume in some respects.
Not many.
But to have,
not many.
Yeah.
But I think it's a great idea. It's a great idea.
Yeah. Well, let me know.
I think the question you'd have to.
Yeah.
Well, I think the question you'd have to answer would be okay. Well, what's the goal? Do I want to have a goal of like really short conversations where we're talking about, here's the things you can do for your wet AMD. Here's the things you can do to prevent wet AMD. Here's the things you can do.
Right.
And then sort of chop that up. But podcasts are timely. So, if you're doing let's say you're doing a 10-minute podcast, you don't want just to have a amalgamation of just a whole bunch of different ones. We say, go listen to episode here. That might be helpful, but the value of podcasts is the ongoing listener. So you may be repeating conversations but I think there's probably some space for that. So maybe you and I can talk about it in the future.
Yeah, let me know, because I think that to have an ophthalmology perspective, and can always bring other people in too, of course, to the conversation, right, from both of our fields, and researchers and patients, even sometimes to hear from a patient who's been through something like an intravitreal injection, for instance. What's it like the first time, or these types of things? People might want to sort of hear that, or what was it like after the injection when you went home? Yeah, my eye was burning and irritated. People might be able to listen to that and make them feel a little bit better and things. So for me, it's just a matter of educating the patients or providing them. And there's so much going on right now that I think that it could be helpful. And it could also be helpful. Just imagine, for instance, from a research standpoint, like there's a new clinical trial going on, right? And the patients are being recruited for the trial. And you could sit down and talk to the primary investigator of the trial and say, what are you trying to find out? What are the risks? What are the benefits? And then the patients would be recruiting for the trial. You just say, go listen to this podcast. So, it could be part of the clinical trials that are coming out. There's this, this way of getting information to the patients, and just from a conversation. Because again, the patients come in, I'm pretty quick with them. The coordinator talks to them, but maybe they want to hear it again when they go home, or play it for their kids and say, this is a trial I'm interested in. These guys are talking about it here. And, some of the trials, some of the bigger companies make up some sort of somewhat fancy, videos and things, but not always though. And it takes them a while to get it out and things. Whereas this would be something you could sit down and do it pretty quick, right?
Hello and welcome to the Chris Wolf Podcast on iCode Media. Today I had a great conversation with Dr. Dante Pieramici, who is a retinal specialist with Retinal Consultants of America. And we talked about a number of things. It was a lot of fun, but primarily I wanted to have him on to pick his brain about a port delivery system for anti-VEGF injections so that patients can have less burden from their treatments for their wet macular degeneration. So I had a ton of fun with this conversation for a number of reasons. I hope you will as well. As always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. I think we're in the best time to practice optometry. Yes, on this podcast, we've discussed the expansion of corporate entities, vertical integration, online retailers, and unproven technology. But I truly believe if we're taking care of our patients and offering the newest and best options for their eye health and vision, These disruptors will only serve as a clear distinguisher between what patients can get from them and what they expect from us. In our practice, we've had a ton of success for our patients in terms of comfort, vision, and stability with proven optical designs of CooperVision's Biofinity Toric. The Biofinity Toric multifocal combines that toric design and its rapid stabilization with the flexibility and customization of the Biofinity multifocal lens. This provides our presbyopic astigmatic patients with an excellent option for minimizing their dependence on glasses. Check out the show notes and link to CooperVision's website for contact lens parameters and more release information. What's things like there for you? Are you in San Francisco?
No, I'm actually in Santa Barbara, which is just about an hour and a half north of LA. As far as the COVID is concerned, not great right now. I mean, we have a lot of it, even in our little area. But weather's nice, 85 degrees, sunny. Can't complain about that. But, but we got a lot of coronavirus out there. The ICUs are relatively full. I mean, LA is just sort of set up. It's kind of a disaster waiting to happen for coronavirus. Just a lot of people live in households where there's 10 people in a house, and a lot of people work sort of frontline jobs in the area and have been out and exposed. And the governor's put on a lot of restrictions. I think some of them are not that great for businesses, of course, that don't make sense, like restaurants. You can't even eat outside in some of these restaurants. So
it's crazy. It's crazy.
Yeah, I know.
But don't you think that something within all these regulations? I mean, it's got to be. Again, I'm not a virologist or infectious disease guy, clearly, but it's just so weird to me that like you have places. It's got to just be more than what's going on, because you got places like that aren't shut down nearly as hard. Right. That they're doing fine, and then you got places like California or New York where their numbers are going up. Yeah, I mean, it's got to be mostly about proximity.
Proximity of people. Yeah, I think it's more of a demographics and what the people look like and how close they live and what they do for work and stuff, as opposed. If you're out in the country somewhere, I'm sure it's relatively safe, right? I mean, there's not that large of gatherings and people aren't living so close together and things. But I mean, as you can see, it doesn't seem to, whatever mitigation strategy that they try, all of them, it doesn't seem to work necessarily, in my opinion. And
does it bother you? Because that's where I'm thinking is that if you've listened, I wouldn't assume that you had, but what bothers me about it is that in this whole thing, there's no it's completely unfalsifiable. Right. If it's the case that our measures work, then we get to pat ourselves on the back and say, hey, look how smart we are. We're awesome. Because we just don't know what the norm is. We don't know what what a normal coronavirus pandemic is going to look like.
Yeah. And then people will try to, after it's all over, they'll try to go back and say this city did this and this city did this. But again, it's like comparing apples and oranges sometimes. It's not like a controlled clinical trial and things. So I don't know that we'll ever know. I'm hopeful for the vaccine, though. I mean, have you gotten vaccinated yet, or?
No, it's a mess in Omaha. The three, unless you're working for a medical center, the three major hospitals in Douglas County, they're hoarding them all. So I've got buddies across the state that have gotten their first doses weeks ago. Yeah. And you just can't get it unless you work for the hospital system.
Right. That's basically the same thing here. They sort of rolled it out in the hospital. So to get it, you had to have a hospital ID or something. And now they're trying to, for instance, the hospitals are trying to get our employees. So we had to send over a list of all the employees, and they have to take their badge or their pay stub to show that they're a medical worker. But they're going to try, to me, it's like they should just be opening up the football stadiums and have people just drive in and give them a shot in the arm and just give it out as much as they can, I think. Worry about a second injection later on and just get everybody vaccinated, because I think that's going to have the biggest impact, in my opinion. But again, I'm not like you. I'm not a virologist. I'm a retina specialist, so I don't even like viral diseases of the retina. So,
Yeah. Do you know anybody that does?
That does what?
Do you have any colleagues in retina that like viral diseases of the retina?
I
They're
think
just kind of
so.
like, oh, this is really interesting, and I feel comfortable
Yeah,
and confident managing it really well.
not that many. I mean, I don't, it's one of those weird disease entities that are tough, right? And they're scary too, because it's like the retina's on fire type of a thing. And, you throw these medicines at them. I'm a mechanical person. I like to fix things, like fix bikes or things around the house where I can use tools. And
Yeah.
I don't know, throwing antiviral agents at things is not as, but I'm glad there are some uveitis people that seem to enjoy it. And, but I don't know, maybe they sort of take it on and then later they think to themselves, God, did I really want this as a career? Yeah. Because we've had a couple
that kind of brings up.
Yeah.
No, go ahead. Go ahead.
I was going to say we had a couple of uveitis people.
Yeah, in your RCA group.
Yeah. Well, in our practice in particular, and as the years have gone on, they've become less enthusiastic about the uveitis patients. But anyhow,
why do you think that is? Do you think it's because they're always hard patients? I mean, in general, it's just not, they have a bad outcome anyway, and
no, sometimes they do well. They just take a lot of work. I mean, there's a lot of tests that you have to order. Then you got to follow up with the tests, and it's a lot of it. They take a long time. I mean, in the retina world today, we schedule patients probably every 5 or 10 minutes, 15 minutes at most. And so
it's crazy.
Yeah. So from just an efficiency standpoint, it's difficult. The uveitis patient comes in, they've got all these medical issues. You got to contact the rheumatologist, the primary care doctor. It's difficult. And then, the testing, your biopsying and things like this are time consuming. So easier, we enjoy just taking a quick look and this is what it is. And let's, here's a shot and see you next month type of a thing. So, yeah.
When you went to, when did you do your fellowship training?
I did my fellowship training in the early 90s and mid 90s, really. And I was down at Emory University. And at that time, we were putting in these ganciclovir implants, which was really one of the first implants for the retina, to provide ganciclovir for the people with CMV retinitis. And I remember we were so busy. I mean, we'd do 6, 7 a day sometimes, these ganciclovir implants, because this was in a time before the antiretrovirals, that they use now for HIV, that pretty much cured the CMV disease for the most part. So it's very rare that we see these types of patients. I mean, they were coming in left and right. And I worked under Dan Martin, who's now the chairman of the Department of Ophthalmology at the Cleveland Clinic. And this was his area of expertise. I mean, his whole clinic was almost just HIV people. And that's pretty much dried up. And that's great. I mean, because those were difficult eyes. And when they detached, it was bad. You put oil in the eye and it wasn't a happy thing.
So that kind of brings up the one, I have a particular interest. I'm actually having dinner tonight. He was on the podcast before. He's a pharmacologist who specifically manages patients with HIV right now at the Med Center, but he's one of my good friends, and my daughter, Anthony Padani, he's at the Med Center in Nebraska. But HIV is fascinating to me. And and so I won't go there because I think it's I'll have a whole bunch of time to talk tonight about it to him. But the what I was going to bring up was that you mentioned that you're mechanical. You probably went into retina because you wanted to do technical things that required high complexity skills, and yet you now made the comment that you're seeing patients every 5 to 10 minutes probably,
right? And
you're taking a look, injecting. What percentage of your day is kind of managed with or taken up with injections?
I'd say probably 50% of the patients I see are injection patients, meaning that they're getting intravitreal injections, mostly anti-VEGF intravitreal injections for things like AMD, of course, wet AMD and diabetic macular edema. And now we treat other things too with anti-VEGFs. Sometimes patients with myopic CNV are getting injections, and retinal vein occlusion patients with macular edema or neovascularization are getting injections, and neovascular glaucoma we're treating. So we spend a lot of time giving injections, and steroid injections as well. We use Ozurdex a lot, and triamcinolone, Triessence in patients as well. So probably 50%. The other 50% is potpourri of retinal detachments, other diabetic patients, dry AMD, and so forth, macular
You
holes.
you can't want to see patients who have dry AMD. That's got to be just sort of something that you're not interested in really managing. You'd rather let the ODs and the primary care or the primary general ophthalmologist do that.
For the most part, yeah. I mean, it's kind of like wet AMD was 20 years ago. I'd see these patients and there wasn't a whole lot we could do. I mean, when I started in retina, we were doing laser photocoagulation. And, once in a while, a patient would present with a little CNV outside the fovea you could actually treat. If it was subfoveal, some people were advocating using laser, but these patients were pretty unhappy with you if you lasered the fovea. So that wasn't a great treatment. Then PDT came around and it was like a little bit better than nothing. It slowed down the disease, but patients don't really appreciate that. I mean, it's like glaucoma patients. It's tough for them to appreciate the benefits you're giving them. And Macugen was the first drug, but it wasn't all that effective. And it was really, Avastin, bevacizumab, which changed everything. So for dry AMD patients, we're kind of at that same period in time. There's really not a lot we can do. I mean, vitamins and dietary discussions and things like that. But I think for the optometrist, this is a good field, good for them to have these discussions with them. We are involved in a number of clinical trials of new medicines that may help patients with particularly geographic atrophy, slowing down the progression of the disease process, a lot of the complement inhibitors and such. So I think there's hope that perhaps we may be at kind of that period we were 15, 20 years ago with wet AMD, where we may just be getting some treatments for that, at least for the more advanced patients. And then perhaps we can start using some of these treatments early on and slowing down the process. But you're right. I think that for the most part, these patients are well served with general eye care, with their ear to the ground that things are coming, so that, they may be eligible for a clinical trial. And that can be real helpful for patients.
Yeah, I think when you get to geographic atrophy, especially if you've got, category 3 non-subfoveal geographic atrophy, that could be close to the fovea, and you may be able to just slow that progression down. What's been your sense in terms of the data you've seen or the clinical experience you have with some of that? You're just halting that progression to make it enlarge? There's nothing right now that's going to take a dry area of geographic atrophy and shrink it. And if there were, what would the mechanism be there? I mean, you'd have to rebuild the RPE. It'd be pretty complex.
Yeah, you're exactly right. And we've been involved in research in both forefronts. I mean, I think the easiest thing, which is not easy to begin with, would be slowing down the progression of GA. And you can imagine a scenario where the patient has central GA in one eye and is having progressive non-central GA in the other. They're noticing these things. We may not measure it. They may come in the good eyes 20/20 every time, but they're noticing that things are, these cells in the parafoveal region are dying off, and they're losing color vision, contrast sensitivity, and probably some difficulty with reading. I mean, as you try to read and there's blind spots and such, it can be difficult. So, if we could slow down that progression 20 or 30 or 40%, that might give them another 20 or 30 or 40% more time with usable vision. I think that's how you kind of look at it. You think just slowing down the progression of this little growing disc doesn't make a lot of sense, but perhaps giving them more time, and they'll really understand that if they've lost the vision in the other eye, and they're quite enthusiastic to be part of clinical trials and things. So that's number one. It's the slowing down of the progression. And I'm hopeful that within the next few years, we may have a product on the market that may be available to help with that. The second thing, as you say, reversing it, that's really what patients would love. I want the vision I had 10 years ago. I said, I don't have a time machine. If I did, I'd get in it too and go back 10 years or so. But we've tried things. I mean, you hear about stem cells, RPE cells, implanting sheets of RPE. None of these things, in my experience so far, have done much as far as reversing the disease process. Again, what we may be doing is putting in some growth factors or factors that may preserve some of the photoreceptors. But again, that'd be a slowing down of the progression. But reversing things, that's a difficult challenge. And cell therapy is being looked at for everything. I'm hopeful that eventually it'll happen, but I'm not so hopeful it's going to be anytime in the next few years. I mean, maybe 5 or 10 years.
That's where the optometrist comes in, right? And Jim and I have had a long history in terms of figuring out how do you prevent. Well, and I guess he was around within. That's how you and I got connected. Is he was around to see us kind of develop. Okay, what is the protocol going to be to try to reach these patients as early on in their disease state as they possibly can, so we can have good conversations about them and intervene as appropriate based on clinical practice guidelines and current evidence. And so, for that, it's like just like everything else, like trying to prevent all the other stuff that we don't want to have, right? If I have a stroke, it's a lot harder for me to have reversal damage, but if I can just make sure I've got a healthy lifestyle and low cholesterol and low blood pressure, the likelihood that I get a stroke is pretty low. So in any case, I think that's really important. What I think is interesting is, if we come back to this idea of, kind of injection, if we're going to talk about macular degeneration, is it seems like in eye care, well, probably in anything, it's always about the timing of stuff that comes out. So I don't know if you've noticed, but from a glaucoma standpoint, we've got new medications that are intracameral injections. No, they're anterior chamber injections with little devices, basically now that release bromonidine. I can't remember off the top of my head what that name of that product is, but anyway, so that now is there to replace a drop. But then on the macular degeneration side, for a while we were saying, okay, well, what kind of drops could we administer anti-VEGF medications through a topical form? We have these wonderful injections, but now can we go topical? So I guess the point is that it's always about like, well, what's the new thing that we can do in terms of delivery systems to probably get us more options for delivery systems? And one of the things that you've been working on is sort of a port system to allow that delivery of anti-VEGF medications over a period of time. So that's kind of interesting to me, and I'd love to talk about and pick your brain about, why don't you think drops are going to be a good use for wet AMD, or why haven't they been? And then why is this an alternative so that you're not having to inject 50 patients or 50% of your patients a day?
I think that it would be wonderful to have a drop, and I appreciate your comments on this, really, because as physicians, what we do is we do a lot of sick care, which means that we take care of sick patients that have sick eyes. What we really want to be doing is doing well care. I mean, we really want to be treating these folks early on when they're younger. We can identify what their risk factors are from their genetics or their eye examination. We start to see early changes. That would be a great time to intervene. The problem is our interventions today are very, sort of risky. I mean, can you imagine a younger person with some drusen and having injections in the eyes all the time? This is not going to happen. So if you want to have a delivery system to be giving to people early in the disease, you want it to, first of all, be efficacious, meaning that you can get the drug to where it needs to be to do what you want it to do, which is prevent really progressive loss of the cells in the eye and eventual neovascularization, or GA. And you want to do it, and you want to deliver it in a very safe fashion so that the risks are low. The benefits are going to take years to appreciate, so the risks are going to have to be low. So if we had a topical drop, that'd be great. I think the problem with most topical medications as far as retinal disease is actually getting enough of it back there so that you can have an effect. And that's been a challenge. I mean, a lot of these are proteins that we're injecting into the eyes, monoclonal antibodies and complement inhibitors that are monoclonal antibodies. And these are relatively large and very difficult to get a high concentration of them to the back of the eye. And you look at there's some pictures you can go online and look at the drug delivery to the eye. People are trying everything, suprachoroidal delivery of drugs, intravitreal injections, intracameral injections, even some devices that you can put into the conjunctiva that will slowly elute drugs. But getting them into the back of the eye is difficult. I think we've had some success with non-steroidal anti-inflammatories. They do seem to get back there enough, but to treat wet AMD or dry AMD, I think we're going to need much higher concentrations of drugs. And so, doing this on a
Well,
long
that
period of, yeah, go ahead. I'm sorry, Chris.
Oh yeah, no, I was just going to ask it because
Yeah.
that sort of leads us to that next point of your time, as skilled as you are, your time is probably best suited doing other things and focusing on other things, and yet here you are kind of making these injections. So I recall a few years ago they were looking at, I want to say it's probably wrong, but spironolactone comes to mind, where maybe they were adding that to anti-VEGF, or there's some sort of topical. Is that correct? Am I remembering that correct? This is 4 or 5 years ago.
Yeah, they've tried a
But to
lot of
try
things.
to
Beta
elongate
blockers.
the
Yeah.
duration, yeah.
Yeah. I think beta blockers is one of the things they've tried, and they've had some success with it. I don't think they've had a real large scale study of it, but yeah, that's not a bad idea either. If you could find something that you could deliver topically that would just supplement it and reduce the burden of therapy, because that's at the end of the day, these injections every month or every 2 months are burdensome for the system. It's burdensome for the patient, of course, having to come in and have these injections. They have to get a driver, and particularly now with COVID and things, these older
Mm.
patients are fearful of leaving and going out. We don't want them to have to go out that much either, but they do want to get these injections, so they come. It's burdensome for our clinics too. Like I said, I spent half the day doing injections, and we could be doing other things, and this would
Well,
certainly be
there's a
better. It's
perception.
burdensome.
No, sorry. There's a
Yeah.
perception. So then the question that I get curious about is, there's this perception that injections are this high dollar value for the surgeon, like surgeons are getting rich off of them. But the reality is that the majority of what you're getting paid with those injections is covering the cost of medicine, not the pressure of your finger on the trigger of
Yeah.
is that the correct assumption?
Yeah, I mean, we do get some compensation from the injections and evaluations and things, but the drugs itself is almost a pass through when you consider the costs of stocking the drugs and managing that. And these are expensive drugs, and they're difficult to manage. I mean, $2,000 we pay for some of these drugs, and if a patient's insurance doesn't pay or the secondary doesn't pay, we could really be up a creek. So there is a little bit of wiggle room with it. There's usually a little overhead percentage, but yeah, but it's not the drugs themselves. They've set it up in a way that we're really almost a pass through. We make money
Right.
on the injections, but that's it's relatively small dollar amounts compared to other things one can do.
It would be more worth your time to do a vitrectomy or to do a retinal detachment repair or something like that than it is to just depress a plunger.
Yeah, in a patient, certainly more
Right.
up our alley of what we enjoy doing, and
Right.
making a big impact. But yeah, so finding
Well,
ways to
well, that leads us.
reduce the,
Yeah.
yeah.
Yeah. Sorry to interrupt. I was
I was
going
just
to
going to
bring
say,
us right into our port delivery systems and other ways that
yeah.
we can do that to use your skills.
Well, so the port delivery system is a device that is being produced and studied by Roche Genentech, and as a disclaimer, and I do consulting for them as well, and I'm an investigator on this project since its inception. The idea behind it is really twofold: to reduce the burden, so the number of injections you put for a patient, and second of all, what we've learned over time is if you look at how patients do with intravitreal injections, they do pretty well for the first year or two. They're pretty consistent with getting the injections. But if you look at real world data, you look at like insurance claims data or Medicare data, over time, the vision drops. It goes back to the baseline. And it seems to be mostly associated with reduced injections. So I think people get burned out, patients get burned out, physicians get burned out. Some of it's the natural disease progression, but some of it really is under treatment in the long run. So it's not a matter of only making the burden less, but to make the burden less may also improve the efficacy of these medicines, 3, 4, 5 to 10 years later. So that's the other hope
Mm-hmm.
with this. So the port delivery system is really, it's a little device that is placed surgically in the pars plana. It's about the size of a piece of rice, and it holds 20 microliters. And The drug device can be refilled in the office. It sits in the subconjunctival space and then pokes into the vitreous cavity. And it has a little release factor on the other side. So it gradually releases the drug. And it's a simple device. It's really like a little bag in the eye that releases drugs slowly over time. And it just follows simple diffusion from the high concentration to the lower concentration in the vitreous. And it's a device that, based on the latter trial, in some patients, on average, in the high dose group, could go almost 15, 16 months without needing a refill.
And
so
the
that's a long.
refills, are they? Sorry. The refills are basically similar to an injection, right? So you don't have to peel back the conjunctiva. You can actually go straight through the conjunctiva into the port to refill.
Yeah, it's a nice little refillable little septum that there is, and it's under the conjunctiva. You can see it. We do it in the office, and it's very similar to an intravitreal injection. A little bit harder for the doctor because you have to find the little septum and hit it perfectly. But from the patient standpoint, it's actually more comfortable because the needle's not going through the sclera. It just goes into the subconjunctiva, the conjunctiva, which we can numb up very well just with topical drops. And so from their standpoint, it's not a big deal. It's a little bit harder for the doctor because you got to find this, you got to come in perpendicular, and the device actually gets flushed out with this special needle, and then it refills it. So it flushes out the old stuff, which is really very low concentration drug, and then fills it with the new high concentration of the drug.
Yeah. So essentially, you're saying that I think it was 100 micrograms per milliliter is the higher dose concentration that was in your study.
That's right. That's the high dose.
Yeah. Sorry. Go ahead.
No, that's the high dose that's the one that's being marketed now. The lower dosages didn't work as well as far as the durability. They were months shorter than that, but the safety and efficacy seemed to be pretty similar between the dosages. So better to go with the higher dose, and it's only 20 microliters in there, but it's a high concentration of ranibizumab. So it's not the same concentration that we inject with an intravitreal injection because we use 50 microliters for that. But it's a high concentration in a small little space, and it slowly leaks out into the vitreous cavity over time. And as I said, there are some patients that can go, on average, the median time to refill is about 16 months. So that's pretty good. And
would you anticipate that this would be a first line? Like, is it fully FDA approved yet? Or you're in phase 3 right now?
No, the phase 3 clinical trial, known as the Archway trial, just reported data. They compared it. They refilled it mandated every 6 months, and they compared it in a non-inferiority trial to monthly ranibizumab or Lucentis injections. And they got equal visual outcomes and equal anatomical outcomes, but only needing two treatments, the fill at the beginning and the fill at 6 months. So at 40 weeks, their outcomes were similar between the two groups. But in the intravitreal group, they had 5 times, 10 on average, 10 and a half injections. So it reduced the treatment burden by 5 times with doing this. So this is the Archway. So it's going to be submitted to the FDA shortly, I think, for a potential approval, and it might get approval then for the use in wet AMD. It's also being investigated now for treating patients with diabetic macular edema and also for treating diabetic retinopathy. So if someone has severe non-proliferative diabetes, we could go ahead and start treating with anti-VEGF agents at this point and reduce the progression of it to proliferative disease and actually reverse some of the retinopathy. So that's the hope.
Then would you think that that you would also be able to use it for patients with proliferative disease instead of having to destroy the retina with PRP? You could use this and it would just prevent, or is it just not powerful enough to once those vessels actually kind of grow into the vitreous? What would your perspective be on that?
It's a great question. I mean, if you look at the pharmacokinetics of it and say compare it to an intravitreal injection, it stays pretty stable. It's probably right in the mid-range of the pharmacokinetics. So an intravitreal injection spikes up a little bit higher, but it comes way down relatively quickly, whereas this is kind of right in the middle the whole time. So It's a real good question. I don't think it's a first line therapy for anything, to be honest with you. I think first of all, you want to make sure the patient's going to respond to anti-VEGF agents. And then you want to determine how much treatment is this patient going to need? Because some of the patients maybe only need to be treated every 3 or 4 months with an intravitreal injection. If that's the case, then it may not be worth going through the procedure with the additional potential risks of the procedure. So, I think it's really going to depend. And so I think what probably would happen is we'd give a few injections intravitreally, shrink down that neovascularization, and then to maintain it in the long run without the neovascularization regrowing, you could put in a device. What we do now is we do PRP laser, as you know, and that's destructive to the retina. And this would be an alternative. You could also just give injections, but the problem is you got to keep doing that forever in a diabetic patient, as far as we know, and that's difficult. I mean, these are young patients, they work and they get other complications. And if they didn't come back, say for 6 months, that neovascularization could come back and they could be in a real dire situation. So this would be a way of treating them long term without PRP. So I think that's a great comment. Good thought.
What about the technical skill involved in placing this device in the first place? Is it going to be a significant uptick for retina guys to learn it well, or is it just part of their existing repertoire of skills they have that they can use on this?
Yeah, it's an interesting question. I mean, as retina surgeons, we do lots of types of fairly complex surgeries, buckles and complex retinal detachment, subretinal surgery, and things. But this is a little bit different. I mean, it's really a dissection of the sclera. We dissect down to the conjunctiva and then laser ablate the conjunctiva, the choroid. We dissect down to the choroid and then laser ablate that, and then enter this space and put the device. There are a couple skills I think that we don't commonly use, and I do think it requires a lot of training because you have to be meticulous in your technique. We have to think about the conjunctiva and think about the fact that we're going to have this device in place for the patients for the rest of their life. So the wound has to be constructed very precisely. The conjunctiva and the tenons has to be covered over the wound because we don't want this device to become exposed. Certainly there are potential complications, and I think the complications of a surgical procedure like this compared to a single intravitreal injection is more. I mean, there's chances of hemorrhage, retinal detachment. There's probably a higher risk in the long run of endophthalmitis or infection in the eye, which can be really, vision threatening for some patients. Yeah. So it's a little bit of a trade-off. I mean, there's going to be a little bit more complications. I think they're relatively reasonable. I think we can mitigate a lot of these complications with proper training and very meticulous technique to this. So, yeah, it's going to require training. Even for the best of the best vitreoretinal surgeons, they're going to have to be trained in how to do this, and they're going to have to be comfortable. And there's a lot of things one can use to train with, and we've been even using virtual reality simulators for the refills and for the training that can give you a pretty good feel for what it's like to do this. So I'm hopeful we'll be able to train a fair number of people to do this in the future.
Then when you think about kind of in the future, so let's say it gets submitted quickly to the FDA, what's the timing? Is it still a year, probably 2 years for full approval?
Yeah, I would imagine it'll be somewhere between 1 to 2 years. It's not going to be one of these expedited approvals because there's plenty of therapy already for the wet AMD patients. This is just an alternative. Usually if you have a disease process such as, say, dry AMD, and you're the first to you're the first to submit, that you'll get an expedited approval because there's nothing else out there. But, patients are being treated effectively with monthly injections. So probably a year or two is what I expect.
Can you walk me through, this is just, I think, the retinal surgeon that I use in Omaha, mainly, there's about 3 guys, and I have a good rapport with him, but I haven't really talked to him too much about his mindset on how he would change his treatment for different patients. But kind of walk us through, when you see a patient in general with wet AMD, how do you know whether or not you're going to treat monthly or treat and extend, or wait for as needed treatments? What's your decision tree on that in terms of your normal protocol?
I'll tell you what I do. There's certainly a variety of different ways people treat, and I don't know that one is necessarily better than another. I'm a person, I tend to treat initially with a treat and extend type mindset, meaning that I'm going to treat till I get them as dry as I think I can. Meaning is if I can eliminate the retinal edema and the subretinal fluid, I feel good. The PEDs or the pigment epithelial detachments are much more difficult to get rid of and often not an endpoint for us. But so I'll treat them on a monthly basis with intravitreal injection and see them on a every 4 week basis for a while until I get them as dry as I think I can. And then try extending them a little bit, maybe a week or two, and
Hmm.
see what happens. If they come back a week or two and there's more fluid and the vision's down and they're more symptomatic, then we're going to cut back to the 4 week interval. If they still look the same and the vision's the same, we may go another couple of weeks. That's generally what I do. I think alternatively, you can consider just PRN, which means you continue to do the same type of thing. You inject monthly until you sort of get them dry, meaning that there's not a lot of retinal edema and as little subretinal fluid as possible. And then you might just hold off a treatment and see them back in a month, and then initiate a treatment again if things start to worsen, be it vision or fluid, or new hemorrhages seen in the eyes. That's a kind of as needed treatment. I think with the PRN therapy, the potential is that not only do you do less injections, but you also may provide them with a longer interval between treatments. And patients sort of see some success in that, like, oh, I don't have to come in every month. I can come in every 2 months. And that's a big
Hmm.
success. It's rare that we get out past 3 months with many patients. I think we start to get worried at that point that we might, be taking too big of a risk. So usually around 3 months is where we sort of decide that, all right, it's 3 months, you're going to get a shot, and then we'll keep you at this 3 month interval unless things look worse. But that's kind of how I think about it. I mean, other people may just consider just do an injection every month, and I don't think that's necessarily wrong. At the end of the day, you'll probably get the best results overall, but you may be over treating quite a few patients that might be able to get away with an injection every 2 or 3 months.
Well, I mean, there's certainly that attitude. I remember there was a study that a few years back, but it talked about head down positioning for patients with macular holes and vitrectomies, and that a 45-degree reading position might be just as effective. There was one surgeon that did it. I want to say it was in Florida with a T in his last name, but I'm always skeptical when I see a clinical study that's one surgeon at 98% effective and self-reported, but I thought that there was going to be a larger study on that, but essentially it just kept head down for 5 days or something like that. And so
Yeah.
I asked the retinal surgeon that I use about that, and he goes, "Well, my 2 weeks of face down positioning works. It works."
Right.
So his perspective, I think, was what you're saying is that, look, I can know that if I do it every month, they may not need it every month, but if the patient misses for a few weeks or we're delayed or whatever, then okay, we're just going to do an injection and we can plan for it. So I think there's something to that.
Yeah. I
Do
mean,
you ever take
I
that
think
approach?
yeah, I mean, I do. I think that, I mean, if you really wanted to simplify it, you just make it a monthly thing and have them come in and get an injection. And if you looked at your population of patients, you probably have a pretty good result overall. I mean, we're always taking a risk when we do, say, PRN or treat and extend. I mean, we're risking a week or two, for instance, and it's possible a patient could come back with a big hemorrhage or something in that time period. So it's a risk we take, and if the patient is comfortable taking that risk, then we do to try to make the burden a little bit better for them because it's not easy to go to the doctor every month, but patients do it. And like you say, if they miss a week or two here or there because they get sick or something, it's probably not such a big deal either if you're doing it every month. So
Yeah.
I agree.
Well, so let
Yeah.
me ask you. Let me ask you a little bit, kind of your experience. Your group was one of the first that sort of had this idea. Is that right? For your This is a totally separate topic,
Hmm.
but for kind of aggregating a bunch of different retinal practices in the country
Yeah.
together. Is that correct? You were one of
Yeah.
the primary ones. When you
Well,
think
yeah.
about the benefits as a retina guy, what's the benefits mainly to collectively be coming together in private equity?
Yeah. I think for us, it's been, I mean, we had private equities in ophthalmology and optometry is nothing new, really. They're trying to do mostly these vertical integrations where they're going to integrate, doctors of ophthalmology with other doctors, optometry, and maybe medical doctors into this vertical integration system. For us, we were really kind of not that interested in that. I mean, we're a retina only group, and we get a lot of referrals from a variety of people. I mean, our referrals are quite desperate. I mean, not desperate, but disparate. I mean, there's quite a lot of optometry referrals. Probably more than half of our referrals come from optometry. We get ophthalmology, primary care, endocrinologists, all types of folks that are referring to us. And so, for us to integrate into a network, I think we would lose a lot of our referrals. And I think that they like sending to us just as a retina only group because, the patients then we keep in good communication and the patients come to us for what they need and we can send them back to their doctor. For me, it was good because we integrated with a bunch of really great retina groups around the country. And we do a lot of research amongst us. And I think there were, sort of best practices lessons to be learned, like how do you manage this, or how do you manage the business aspect of this, or how do you do research? How do you train your technicians? How do you train your research coordinator? So I thought there was a lot to learn by sharing these things. The more brains, the better, right? One brain's good, but 50 brains are much better. And so part of it was just sharing information. And I think working together, we can develop a real great research platform to bring to clinical trials a lot of these new drugs and things in a very organized fashion amongst our different sites. And, there's a lot of consolidation going on in medicine. And I really, I think a lot of us wonder, what does a retina-only practice look like in 5 or 10 years? And I think that this is one potential scenario, is that you don't integrate locally as much as you integrate nationally to try to efficiency of scale and such. So I've been pretty excited about it in the last year, and I think that we work together. It's a doctor-driven organization. I think the people who in the business aspect realize that the product really is the doctors, and so we want to have the best trained doctors. We want them doing ethical procedures. We want them to be offering patients the possibility to be part of clinical trials if they don't have therapy, because I've seen how it works. I mean, I have patients that are still reading and driving that got involved in our clinical trials of anti-VEGF agents 15 years ago. And I know that they wouldn't be seeing now had they not been part of those trials. And so there's a lot of power to that. And in our field, there's still a lot of unmet need, dry AMD, geographic atrophy, PVR, bad diabetes, non-perfusion, lots of things that we can help patients with in the future, and a lot of genetic diseases as well.
Well, I'll be respectful of your time, Dante. This was a lot of fun for me to kind of pick your brain on your experience and even just kind of take a peek behind the curtain. So thanks for being on. I really appreciate it.
My pleasure, Chris. Good talking to you as well. And